Every day, Kenyans queue in different hospitals to seek medical attention, a human right as per Article 43 of the Constitution. However, this human right is yet to be fully enjoyed by most Kenyans. According to a report by the International Commission of Jurists, for Kenyans to fully enjoy the right to health, there needs to be availability, accessibility, acceptability, and quality in the available health facilities. However, this has been inadequate due to the low supply and frequent stockouts of medicine and commodities as exposed by the COVID-19 pandemic.
At the time also there were a lot of corruption scandals around cancer, around counties not having adequate resources to respond and meet the pandemic needs. There's also increasing concern around the healthcare providers, the doctors and the nurses, their quality of their work environment and their terms and conditions of service was also a concern. So all these issues culminated into ICJ asking ourselves, why isn't the government meeting the obligation provided in the Constitution?
Health being a devolved function, 33 out of the 47 counties have attained the World Health Organization target on health facility density.
The two levels of government are not working seamlessly to ensure that this right is delivered because there are some functions which belong to the national government, some functions belong to the county government. However, we are not seeing that consultation and cooperation between the two levels of government.
So when we ask for information, for example, what happened to the equipment that for the COVID, that were, purchased or Kenyans collected money, nobody seems to give that information. So there's the corruption allegations. This again goes back to our prognosis and diagnosis of the ICJ. There's a systemic problem in our healthcare system, both at the administrative organs, including the provision of services.
And in order to achieve the universal health coverage, Sustainable Development Goal by 2030, there is a need for the government to eliminate discriminatory practices common within the health systems.
What we recommend is that there's a need to review the existing laws and policies from a human rights-based approach, because health is a human right. So the government needs to review the policy and legal framework and strengthen it to ensure that as the laws and policies are being implemented, they are also achieving the human rights. They're being implemented from a human rights-based approach.
The jurists therefore recommend that the government, through regulation and advocacy, ensure the improvement of access to quality healthcare and for Kenyans to access the possible health standard of healthcare. Robbie Omondi, K24 Newscut.
Good afternoon, ladies and gentlemen, and thank you for joining us for today's webinar, coming to you live from ICJ Kenya House. My name is Christina Kenyi, and I'm also joined by Vincent Kimathi, who will be co-moderating today's session. The right to health is national, regional, and international legal frameworks. The right to the highest attainable standard of health is among the economic and social rights contained in the Constitution, Article 43. Similarly, Article 2.5 and 2.6 of the Constitution provide for the application of the general rules of international law and any treaty or convention ratified by Kenya as part of the laws of Kenya, which elevates the status and application of international treaty obligations. The Constitution also devolves the health function, departing from the centralization of health to a devolved system.
Beyond the Constitution and international treaties, Kenya has also enacted the board include the Kenya health policy and the Kenya strategic plan. It is coverage to support the realization of the right to health in Kenya. However, according to the United Nations High Commissioner for Human Rights, because of people are routinely excluded the commodification of care, the underfunding of the health sector, poor prioritization, discrimination, and poverty.
Despite numerous legal frameworks on the right to health in Kenya, attaining the right is still challenging for most Kenyans. The UHC program meant to solve the cost challenge in health sector has been slow, with its progress further exacerbated by the COVID-19. The economic implications of the COVID-19 pandemic put more Kenyans at risk of being pushed into poverty by healthcare costs directly arising from the COVID-19 treatment or other conditions.
Similarly, the devolution of health services has had significant gains and monumental challenges. These challenges include frequent strikes, poor cooperation and coordination between both levels of government, which is demonstrated on issues, and frequent delays in the transfer of funds, to mention a few. The COVID-19 pandemic also exposed the weak systemic links between the coordination of the national government and county units. Globally, the outbreak of the COVID-19 pandemic created unprecedented challenges in the health sector, which jeopardized the sector and human life. There was a sudden rise in the requirement for isolation beds, ICUs, and other life-saving facilities.
It is upon this background that we are hosting this discussion today. To help us unpack the issues, we are joined by two distinguished panel of experts on health governance, medical and legal practitioners. I now hand over the program to Vincent to introduce the ICJ Kenya Council Chairperson, Mr. Prota Sainde, to give opening remarks.
Participants of the day, please allow me and join me to welcome ICJ Kenya Chairperson and Council Chairperson, Mr. Prota Sainde, to give his opening remarks to start us off for today.
Good afternoon. On behalf of ICJ Kenya Council. Yes, thank you, Vincent, thank you. On behalf of the ICJ Kenya Council and the Secretariat, let me begin by recognizing and appreciating members of ICJ Kenya and academia for taking time off your busy schedule to attend today's webinar. We also thank all students from different law schools for joining us as we host this webinar on the right to health in Kenya. I hope our presence here today will intensify collaboration between academia and ICJ Kenya to initiate discussions on the role of legal practitioners and explore new channels and alternatives to improve legislation and policy that enhance the right to health. Distinguished guests, as an institution that promotes human rights, advocates for the rule of law and compliance with international human rights standards and best practices, ICJ Kenya conducted a review of existing legal and policy frameworks related to the right to health in Kenya and made recommendations for improving the legislative and policy environment for achieving the right to health, enhancing health service delivery, awareness on the right to health, and stakeholders' engagement in the right to health advocacy. To this end, we have convened this webinar to disseminate the report titled A Review of the Legal and Policy Frameworks on the Right to Health in Kenya, as well as to enhance awareness of the right to health in Kenya among legal practitioners and law students. The review report is among the series of knowledge products under our Right to Health project. It underscores how strengthening legislative and policy reforms and interventions is essential to improve access to health services at the national and country level in Kenya. An enabling legal and policy framework for health is vital to realizing the right to health as enshrined in the Constitution of Kenya 2010. Furthermore, advancing the right to health requires commitment and action from duty bearers and right holders. Distinguished guests, as an organization, we have taken a strategic direction guided by our strategic plan of 2020 to 2024 to promote the respect and enjoyment of economic, social, and cultural rights, abbreviated as ECOSOC, with a special focus on the right to health as enshrined in the Constitution of Kenya 2010. I call upon ICJ Kenya members academia, and law students present today to join us in championing and promoting the respect and enjoyment of the constitutional right to health in Kenya through legislative interventions. While we strive to achieve the objectives of this forum, I wish to challenge us to think of ways of improving access to health services at the national and county level through legal and policy interventions. Let's reflect on promoting the realization of rights to health in Kenya. I thank you once again for joining us today and take this opportunity to welcome you officially to this webinar. Thank you.
Thank you, ICJ Kenya Chair, for the insightful remarks. So now we'll proceed to our speakers of the day. We have two speakers with us. We have Dr. Charles Oyaya. Dr. Charles Oyaya, just say hello.
Hello and good afternoon to everyone. Thank you, Chair.
Okay. We also have with us Dr. Kahura Mundia. Can you say hello to the participants?
Good afternoon, everyone.
Okay. So now I'll proceed to introduce the first speaker who will make his presentation. Our first speaker for today is Dr. Charles Oyaya, a constitutional law, governance, public policy, health, WASH, and development planning specialist with extensive multidisciplinary professional experience. Dr. Oyaya holds a PhD in law, Masters of Arts in Health Management, Planning and Policy, Masters of Arts in Urban Planning and Regional Planning, and a Bachelor of Arts in Sociology. So he will be presenting an overview of the report titled A Review of the Legal and Policy Frameworks on the Right to Health in Kenya. Karibu Daktari.
Thank you very much, Christian, for that elaborate introduction. Thank you, Chair and colleagues, for the introductory remarks that you have shared. Mine today is to share the results of a study that was carried out on the legal and policy frameworks that inhibit the right to health in Kenya. And I think I'm going to share on the presentation.
Hello?
Okay, thank you. I hope we are all able to see the screen.
Yes, you can see your screen, Dr.
Thank you. As I dive into the presentation, I just want to make a few comments. Number one, we start from the fact that the right to health is one of the socio-economic and cultural rights that are guaranteed in the Constitution of Kenya. And when we talk about guaranteed, basically it means it has full force of law in terms of ensuring every person enjoys that right. But what does that right constitute? If for nothing else, but for holding accountable those who are vested with a duty to ensure that every Kenyan enjoys that right. How does that accountability play against access to health services? The very language of that right is that every person is guaranteed the right to a highest attainable standard of health, which includes the right to healthcare services, including the reproductive healthcare services. So the whole question of holding accountable those who are vested with a duty and ensuring that those who should enjoy that right enjoy it to the greatest extent possible becomes key. Having said that, I would also just want to mention that if that right is guaranteed for every person in Kenya, our Kenyans are actually enjoying their right to health as guaranteed by the Constitution. If they are enjoying it, to what extent are they enjoying that right? And if they are not, then what are the factors that inhibit their full enjoyment of their right to health? And if at all there are factors that are inhibiting their full enjoyment of that right, then what can we do at our own level to breathe life into the right to health and to ensure that every person enjoys that right? The chair in his introductory remarks has given some guidance on what this would mean. One is from a policy and legislative context. Is it enabling enough? And that is a question that is clearly addressed under Article 21 that requires that necessary policy, legislative, and other measures, which include setting standards for the progressive realization of the right, are actually put in place. It goes further to require investment, and very clear investment, putting resources in place for the full enjoyment of that right, and taking into account the various vulnerabilities that may characterize the society or people in that society. The second aspect is the whole question of practice. Are we enforcing the right? Are we protecting that right? Are our systems, judicial systems, for example, enabling the full protection of the right to health? And last but not least is the question of access to services. So this study, as clearly alluded to, is about looking at the environment within which the right to health is administered and is enjoyed, and whether we clearly understand what that constitutes, and whether at the end of the day, the people of Kenya in their diversity are enjoying that right. Having said that, and without probably belaboring the point that has been mentioned before by my colleagues and the chair, is the very fact that before the Constitution of 2010, the very element of the right to health was not clearly presented in our Constitution, neither was it taken as, if you like, a guaranteed right for that matter. And the Constitution 2010 has therefore brought into fundamental shift the whole question of approach to service delivery, to governance, and, if you like, the very fact that the people have their right and can actually demand for their right and claim that those rights are in one way or the other violated or denied or even threatened, depending on what the situation is. And when we're talking about service delivery, is a question of who has what responsibility at what level. And that brings in the whole question of functional division of labor between national and county government. And not only functional, but also fiscal responsibility and assignment for that matter. Having said that, again, there are basic assumptions that the Constitution does bring into the fore, one of which is the very fact that wherever a function or a responsibility is assigned, there should be requisite resources. And therefore, we are not just talking about responsibility and functionality, but also resources that would be required to ensure that responsibility is fully exercised. In terms of actual intervention, Kenya over the last few years, rising from the global commitments that we have undertaken, and the very language that is presented in our constitution guaranteeing the right of every person to health care services, to health in its diverse dimensions, we have come up with a program that is called Universal Health Coverage. And remember, when we are talking about health being guaranteed for every person, it then means no one should be left behind, irrespective of your situation, irrespective of your condition. And this is where we are proceeding based on the very fact that, yes, the right gives that opportunity, but to what extent are we executing that right to ensure every person enjoys that right as defined by the Constitution, by law, and by policy. Having said that, I think the right to health is understood, and I think Christine and colleagues have clearly articulated this, that we are all enjoined as part of the global community to ensure that these rights come to bear. And this is recognized by our own constitution, as had already been mentioned under Article 2, and taking into account Article 21.4 that requires us to come up with enabling legislative instruments to meet our global obligations, that indeed that we have obligation not only in the domestic context, but within the global context and regional context. And I cannot overemphasize this. And therefore, one of the objectives of this study was also to look at practice elsewhere and what those obligations are at various levels of our, if you like, engagement. I think as we talk about the right to health in the global context and the economic, social, and cultural rights, we do take into account that there is some policy guidance in terms of what these obligations are, core obligations and obligations of comparable priority. And I would not want to get into this, but the very fact that these core obligations are directly applicable to us, and we would ask that ourselves, therefore, how do they play and how have we played with them in our own local context, given the uniqueness of our context. And again, I will not just get deep into that. Again, when we are talking about the right to health, we must understand it within the broader context of human rights, and therefore appreciating the various linkages. So therefore, when we talk about the right to life, right to health, it has implications on other, if you like, rights which bear for to each one of us. And I believe if you look at Article 43, that actually is what is, if you like, alluded to. That when we look at the right to health being at the center in this context, we would look at it in relation to other, if you like, happenings within our own context in relation to rights. And the chart that you see before yourselves does indicate to this. So if you're talking about human rights violations, whether they are of gender nature, whether they are age-related, whether they are racial, ethnic, or otherwise, then they have direct implications on the right to health. Of course, when we are talking about right to development, which is clearly demonstrated in our global commitment on sustainable development goals, again, you will see that the right to health under sustainable goal number 3 will be affected by several other elements as they would obtain. Then, of course, the whole question of vulnerability within our context, and therefore the way our right to health, for example, in the context of our constitution, is very much alive to the multidimensionality of how we approach the whole question of the right to health. Of course, when we are talking about the right to health from a service perspective, and that the right to health is not just in terms of the general statement of health as defined by WHO as to being the complete, if you like, state of our mental, socio-economic, cultural, and not just the absence of disease, then we look at it also from the perspective of people actually having access to the services that will breathe life into this right. And that is where under Article 12 of the socio-economic and cultural rights, the committee on those rights has identified, if you like, a guiding framework that when we talk about the right to health, its essential elements is on availability of public health and healthcare facility services and goods in sufficient quantity. And we will be looking at people really accessing these services. Are they available? If they are available, to what extent are they sensitive? For example, you're talking about adolescents, or you're talking about mothers, or you're talking about children. To what extent are these services delivered in a way that is cognizant to their unique placement within the society? So to that extent, how acceptable are those services? How accessible are those services from a physical point of view, social, cultural, or economic point of view? Are the services affordable? Are people able to access them, or will they spend beyond their means selling their assets to enjoy that right to healthcare services? And last but not least is the quality aspect. If you hear or listen to the pronouncement on the right to health under Article 43, is about highest attainable standard. Wherever we are talking about standard is a question of quality. So therefore, as we are going to ask ourselves, what are the factors that are inhibiting the enjoyment of the right to health? Then this is going to be of critical importance. Having said that, I think in terms of just the very fact that there are various dimensions to the right to health, our Constitution has clearly made provisions that aim at protecting the human right to health. And there are several provisions which I've listed here. I will not go into them. And one can just see how important these provisions are. And therefore, when we are looking at Article 43, we cannot look at it in isolation, but in relation and being read in relation to other provisions of the Constitution, which take into account also our international obligations. From the face value, we have a very, if you like, robust legislative and policy framework for the realization of the right to health. And they are in various, if you like, statutes, and this is not the full list. There are so many, but this can just give us an example. From the service delivery point of view, the health sector, we have two anchor legislative instruments over and above the Constitution, the Health Act 2017, then the Public Health Act. And Public Health Act Cap 242 is not 20, Cap 242, and which is a very old legislation, first enacted in 1923, and still remains to bear within our legal space. I would want to mention that this particular law has not fundamentally been amended to align with the Constitution, but remains in operation. Of course, from the policy perspective, we are all committed to meeting universal health coverage by 2030, and this is clearly stated within the Kenya Vision 2030, domesticated in the context of the Kenya Health Policy 2015-2030, not 2020. And of course, there are also several other executive orders that have come to bear on this question. But having said that, this study has been taken in the broader context or scope that relates to how the question of the right to health is demonstrated within our Constitution, within the legislation, and how this can be actually tracked, which is clearly in the context of county governments under the County Government Act, Section 113, that provides a window for tracking, if you like, the status or the extent to which households and individuals within those households are enjoying their rights as guaranteed under Article 43. So why this study? This study is informed by 4 key considerations. One, the very fact that millions of Kenyans are routinely denied their right to health and are excluded from the existing health coverage for various reasons. If we take it from the AAAQ, then one can see the very fact that not many people are enjoying this right, either because of underfunding, a high cost of care, poverty, discrimination, or just low prioritization of the question of health within our decision-making environment. 2 is the question of transition to devolution. Critical challenges, structural, systemic challenges continue to bear, and which are excluding many people from enjoying their right to health. And last but not least is the question of political will. Yes, we may have resources available to various things, recurrent, consumption for travel, but when it comes to ensuring that those rights are actually fulfilled from the investment point of view, then you find many questions abound. And therefore, not only from investment, but just even the national government are fully delivering the mandate to counties as would be expected by law. So the situation, as it were, continues to be dire. We are facing triple burden of diseases, whether they are affecting children, the general population from communicable diseases or non-communicable diseases perspective. The indicators are not improving. Actually, some of them are, instead of improving, are being downgraded. The very fact that many of the conditions that we spend money on can be easily prevented. And the very fact that the health service delivery environment is not ready to deliver. Instead of improvement, the health service readiness indicators are actually declining. And last but not least, from a resource perspective, although the Constitution says where the function is, resources should be there and should be matched, we see disproportionality between national and county health systems in terms of sharing resources to deliver. So I would basically say that this can be demonstrated by just the chart that you see on the screen, that although the assumption is that most of service delivery functions are devolved to the counties, and that would mean that resource allocation for national level delivery, which is largely policy and specialized care, should be reducing. It has been increasing over time, and the resource envelope available for counties remains highly restricted, and therefore their inability to deliver the services that they are mandated and commanded or obligated by the Constitution to deliver. So therefore, as has been mentioned before, that the very significance of this study is found in 3 dimensions. In contributing to improving legislative and policy reforms that would ultimately enhance the right to health. 2, improving service delivery, and 3, empowering the citizens, for that matter, to enjoy the right to health. So I wanted to basically mention this so that as we are going to look at the question of what we need to do, then the point will be to what extent will we contribute to these dimensions. So what were then the objectives of this study? One, the overarching objective was to review the existing legal and policy frameworks. And if you have the document with you, the full research report, then you will see that we have made an attempt to do a comprehensive and in-depth review of these frameworks. And we have therefore also identified the key gaps and made recommendations thereto. Specifically, we were to look at those frameworks and asking ourselves the extent to which they are actually inhibiting access to healthcare by all or majority of the population. 2, looking at regional and global contexts, particularly from a normative perspective, and to the extent to which this has contributed to the discourses that we have, particularly in the context of health emergencies. Christine and company had made reference to the impact that is still very much alive to us in relation to COVID-19, which now is again rearing its head. The whole question of intergovernmental relations, as we mentioned, that the Constitution is clear on who should play what role at what level, and given very clear directive in terms of how the 2 levels of government should interact and relate with one another. The question would be, to what extent are they doing that to ensure that we actually deliver in a seamless way? And last but not least is the question of information, access to information, and the right to health. How are those 2 playing in the context of the devolved system of governance and service delivery? How did we approach this? In terms of methodological approach, we adopted a design that was to the greatest extent qualitative. We reviewed literature. We conducted synthesis and analysis of evidence that is available, carried out key informant interviews, and held, if you like, workshops and roundtables that engaged various stakeholders. And the table that you see are the categories of stakeholders that we engaged. And these were very, I would say, very vibrant platforms for discussion. These were also platforms for validation, not only to generate evidence, but also to validate that indeed the findings that are contained in this report are reflective of the voices that we captured. Ladies and gentlemen, let me therefore just indicate some of the emerging, if you like, some of the results from the overall assessment. From the legal policy and the health system perspective, in our overall assessment, we do recognize that Kenya has made efforts, not only in terms of its commitments to global obligations, but has also made efforts to enact what would broadly look like enabling policy and legal environment, including a health system that ideally should deliver, functionally defined in terms of roles and responsibilities and resources clearly given guidance on in terms of allocation and allocative decision making. However, having said this, we have noted a few, if you like, gaps, not quite few, there are quite a number. First, that one, despite the promulgation of our constitution in 2010, we have not fully or comprehensively reviewed the policy and legal frameworks to determine the extent to which they are aligned to the right to health and the constitution as guaranteed in the constitution. Number two, it is emerging that some of the laws and policies that we are enacting are actually contradictory. And a number of laws that have been enacted, there are cases where they are being taken to court, challenging their constitutionality. For example, the Health Act 2017 is still a contested piece of legislation and has been taken to court by Council of Governors that it is not speaking the language that it should speak, being sensitive to the devolved system of governance. The same applies to KEMSA Act, for example, and several other acts and guidelines, even to a certain extent, and regulations. Number three, that despite very clear constitutional guidance and guidance given under the Public Finance Management Act, the County Government Act, and other attendant legislations, the planning and resource allocation behavior are not aligned to the Bill of Rights, which under Article 19 says that all socio-economic and cultural policies shall be founded on the Bill of Rights. So we see that planning and resource allocation are not exactly aligned with the rights-based approach that is clearly defined by the Constitution. Number four is lack of clear legal and policy guidelines on management and implementation of concurrent functions. Under Article 186 of the Constitution, the functionality is defined in three dimensions. That functions are either exclusive to national and county governments, or they are concurrent in the fact that it brings together both national and county government in terms of responsibility, or they are residual. Anything that the Constitution has not defined then belongs to the residual realm, where it is assumed that function will belong to the national government. I would want to say that despite that, we have not come to clearly provide guidelines on how, particularly, to implement and execute concurrent powers and functions that are provided for under the Bill of Rights and also under the fourth schedule of the Constitution. Number five is the question of judicial enforcement of the right to health. The Constitution does require the Chief Justice to enact enabling rules for the interpretation and application of the rights that are provided for under the Constitution in the corridors of justice. Yes, the Chief Justice in 2013 did enact some, if you like, rules to that effect. But the question is, to what extent do those rules apply to enforcement of the right to health and other rights guaranteed under Article 43, including the right to a clean and healthy environment under Article 42 of the Constitution? My take is that there are no clear, if you like, guidance on how to deal with this. And I think the cases which have been adjudicated before the courts does reveal the challenges in interpretation of the right to health and appropriate remedies that should be offered should those rights be violated in one way or the other. Last but not least is the very fact that the courts in their approach are still taking the limited available resource approach, which the Constitution under Article 21 has actually done away with. But that is still the approach, and making it appear as if that wherever the state says that they do not have available resources, then that is adequate, even though the law, the Constitution does say that it will be the responsibility of the state. Ideally, the minimum content, the minimum essential package should be the guiding principle, not necessarily just the inavailability of resources.
Can you wrap up in the next 10 minutes?
Okay, thank you. Just in relation and just being sensitive to the participants in this webinar, indeed, over the last few years in the context of the Constitution 2010, we are seeing an upsurge in cases being instituted in our courts, claiming that rights relating to health are being violated. And in the report, we did review and presented the claims, the findings, and the determination of the courts that we can look at more in detail at our own time. But what is clearly emerging from these cases that have come up in our courts relating to claims on violation of the right to health is one, that we do appear not to have effective normative guidelines for the interpretation on the right to health and appropriate remedy, as I mentioned. The rules of 2013, the Constitution of Kenya, protection of the rights, rules of 2013 do not clearly provide effective guidelines. And number two, there is very clear apparent difficulties that the courts are facing in litigating, that we are finding in litigation of these cases, particularly in proving that a violation did actually occur. And if you review some of those cases that we have shared, one would be able to appreciate that. Then the third dimension is a question of resource constraints and the impact on this. So far, no one has clearly gone to court to claim that the state has not invested adequate resources to realize this. But I think it is a potential area for public interest litigation where resources that are available are not well aligned with the delivery or realization of these rights. And last but not least, I would want to mention that broadly looking at these cases, one would actually see that the denial of these rights are exacerbating, if you like, the health status, the poor health conditions of the population. And that calls for, if you like, a paradigm shift on how we can approach these cases when brought before the court. So just probably in summary, and we can look at this more in detail, that looking at some of the challenges and factors that inhibit the right to health, we can look at some of which I've already spoken to. One, the question of standards of state obligations. These are not clarified, neither are they fully operationalized at both national and county government level. Across the board, if you take the 333Q criteria in terms of assessment, the resources are not only available for majority of Kenyans, they are largely inaccessible even from the economic to many, in many instances, they are not applied to, if you like, the needs of the population, and the quality remains a challenge. Two, the delivery of services anticipates the hierarchy of services provided. And in Kenyan context, this is defined in different levels, and the referral should take that into account. And we did note that the emergency and referral system is fairly weak. The adequacy of legal and policy framework is in question. As we had mentioned, the fiscal decentralization and accountability remains weak. The major instrument for financing health and ensuring universal health coverage, which is codified in the National Health Insurance Fund, is not working. Actually, there's a clear disproportionality that, for example, despite 70% of Kenyans receiving services from public facilities, only 30% of reimbursements go to public facilities. 70% are going to the private sector. So I would want to mention, just in a nutshell, that when we look at the challenges and factors in the context of service delivery, we have a huge challenge. When we look at it at policy and legal dimension, we have a challenge. When we look at it in health system dimension and taking into account even the 7 or 8 health system building blocks, we have a challenge. When we look at it in the context of health emergencies, we have a challenge. Despite, for example, Article 43(1) Clause 2 providing us with the right to, if you like, emergency medical treatment, it remains a big challenge. When it comes to information, awareness, education, it is a challenge. When it comes to workforce, and we know health service delivery is human resource intensive, we have a challenge. When it comes to financing, as I mentioned before, we have a huge challenge. So on the basis of that, we have made specific recommendations around 6 key areas. One, the need to deepen legislative and policy reforms, which is still an ongoing, even in the context of transition that we still have. 2, strengthening health system and institutional environment, including intergovernmental responses. 3, access to quality healthcare for all, and that is really the anchor that is found in universal health coverage. A clear strategy on management of health emergencies and preparedness, and of course, the whole area of empowerment of citizens through awareness and education and so on and so forth. And last but not least, sustainable health financing. As I mentioned before, that the construct of our constitution is that wherever there is a function, there should be adequate resources and adequate provisions are provided. But the question when it comes to planning and allocation, then they are diametrically opposed to one another. So let me just basically say that those specific recommendations are there in the detailed report, and we can respond to specific questions as they come. Let me just say in conclusion that from the face value, the current policy and legal framework appear to be robust, but there are many challenges and barriers that are inherent in them that are inhibiting the enjoyment of the right to health. Secondly, the standards of the state obligations are not clearly defined, and therefore holding the state accountable is fairly difficult, as I already even indicated in the cases that have come before the courts, as it were, and continue to come. Number 3, the court's approach to adjudicating on matters of violations or infringements or even denial of the right to health remain something that requires, if you like, a transformation, just a 360-degree turn, so then they can, if you like, enforce this much more strongly. And last but not least, the right to health as currently enacted. And this is what we say in overall. In our laws, in our policies, in our plans, and in our resource designs are not sufficient to deliver, to protect, and to fulfill these rights, as it were, to every person in the language that clearly the Constitution has provided. So let me just stop at that point, and thank you very much for listening to this presentation. Thank you, and back to you, Christine.
Okay, thank you very much, Dr. Charles, for that summary of the report. And as you are going through the report, there are some things that were running through my mind, and I was asking myself, and most of the listeners and participants must be asking themselves the question of how available is our health in Kenya? How is it acceptable, accessible, and does it meet the quality that is expected? And who else to answer that question than the next speaker of the day, Dr. Kahura Mundia, a medical practitioner who will be speaking on perspectives of the health system related obstacles to realizing the right to health and emerging legal and policy challenges. And just to read a little bio of our next speaker, our next speaker is the Deputy National Chairperson of Kenya Medical Practitioners, Pharmacist and Dentist Union. He has an aggregate of over 10 years experience in the dental profession, over 6 years experience in healthcare management, health systems, healthcare, legal and labor affairs, and policy development. Dr. Kahura Mundia holds the following academic and professional qualification among the many. One is an MBA in healthcare from Strathmore Business School. He has an LLB from University of Nairobi. He has a Master's of Dental Surgery in Oral and Maxillofacial Surgery, or facial surgeon. He has a Bachelor of Dental Surgery from the University of Nairobi. And last but not least, he has a Diploma in Information Technology from JKUAT. Karibu sana daktari.
Asante sana.
Yeah.
So I can begin?
Yes.
Okay, is the presentation ready?
As we are projecting Daktari's presentation, for our participants, please continue engaging us through various platforms. Send us or write questions on the platform, on the Zoom platform, for those who are joining online. For those who are watching from our different platforms, you can use hashtag right to help to continue the conversation on Twitter. We are on Facebook, ICJ Kenya, YouTube, it's ICJ Kenya. And for Twitter, if you want to tag us, please tag us at ICJ Kenya. Oh, please bear with us as we are projecting Daktari's presentation. Yeah. Please proceed.
So it's on slideshow? Okay. Okay, thank you. So the topic for today and what we have been dealing with is checking on how the legal and the policy space in Kenya affects the healthcare sector. And I give a perspective riding on to what our previous speaker, Dr. Yaya, has delved upon. So the subject was the obstacles in realizing the right to healthcare as enshrined in the Constitution of Kenya, Article 43(1)(a). So in the outline of this discussion today, discourse today, we'll do a brief introduction, do a review of the relevant laws that are guiding healthcare, and some of the healthcare frameworks that are applicable all over the world and how they marry into our legal space, as well as look at some of the challenges and discuss aspects of how we can get recommendations on the same. So I'll share that picture in the introduction. It shows a four-wheel vehicle on the rough road, and it's a four-wheel because it's made to drive and withstand the rough terrain, and there's something that's happening there in that picture. With that picture, we could use that as an analogy whereby, as per the WHO building blocks, you can take the example of, let's say, the front wheels and the back wheels. Whereby one of the front wheels, you can say that is probably the human resource aspect, whereby that vehicle moves on that. The other wheel will be like the human healthcare financing aspect. And the other wheel will be probably the back wheels. One of them will be like the commodities and the drugs aspects. And one of the other wheels, the last one, will be, let's say, the health information management systems that are used in the healthcare space. So this vehicle is probably having a driver, and the driver knows what he's up to. And that is the aspect of the healthcare leadership and governance that drives the aspects of the healthcare rights delivery. So move on in defining what is a healthcare system. So like you all had, a healthcare system consists of all the organizations, institutions, resources, and people whose primary purpose is to improve the healthcare of the people. And this is affected by many other aspects affecting healthcare. And the function of a healthcare system is to deliver preventive, promotive, curative, and rehabilitative interventions through combination of public health actions. And the system is designed in a way that you have the lower level all rising up in a pyramid-like fashion to the tertiary level of healthcare delivery. And both persons who are supposed to give this healthcare is the state and both private providers, and that now forms the stakeholders of the healthcare space. The actions of any healthcare system should ideally be responsive, financially fair, equitable, and with equity whenever we are providing services as both providers and persons responsible for healthcare services delivery. The system needs staff, funds, information, supplies, transport, communications, and a lot of other things for it to function efficiently. And we have been discussing this because we want to strengthen the healthcare system in Kenya. And we are doing these studies, these discussions in a bid to strengthen the healthcare systems. So we look at the place of the relevant laws in Kenya. We have particular laws that are listed there, particularly where we have the Medical Practitioner and Dentist Act. This is a law that defines the requirements of all practitioners, the licensing of facilities, the licensing of providers, qualifications that are supposed to be done, as well as the curriculums of training. So that is a very important law in Kenya. We also have the Healthcare Act, which was made in 2017, which also defines the aspects of how law should be delivered in the country. We also have another law, because there are many players in the healthcare space. You have pharmacists and the aspects of medicines. So there's a particular law that defines that, that's a Pharmacy and Poisons Act. And then you have the other supplies law, which is the KEMSA Act, which provides for how medications and other medical equipment are supposed to be shared between the public facilities or any person who wants to procure such equipment. We have other recent laws which have come up, and that is because of what is happening in the healthcare space. And we have the cancer scourge that's coming up in Kenya. And out of the state's duty, a law was made to try and improve and strengthen the delivery of the right to healthcare as regards cancer prevention and control. And more so, we also have another law, which is the data protection law. Now, this one helps to control how information between patients and hospitals and other persons, the payers, is supposed to be shared across board. We have also other laws in the Kenyan space. We have the employment laws now, which control how the contracts of employment between providers and hospitals and the public sector, how all that plays in there. We also have the insurance law, which caters for the private insurance, as well as the insurance medical schemes. And the NHIF has its own particular law, and that's why it's probably not listed under the insurance law. We have other new laws, like the Competition Act, which also is supposed to control how both players in the public and private space are supposed to deliver the right to healthcare in the aspects of service delivery and the facilities. Like I said, you have the NHIF Act and the Public Finance Management Act, and the recent law of the County Government Act, which tries to define the roles of the county governments in the delivery of the devolved functions. We also have a new law, which was made in 2021, the Public-Private Partnerships Act, enacted in December 2021, and it's yet to be realized. The benefit of that law is yet to be realized in the healthcare space. So that's another thing that we'll discuss. Lastly, we have the Universities Act, the TVET Act, as well as the KMTC Act, which now defines how these persons providing healthcare are supposed to be trained and what is expected of them. We'll deal now with one of the laws, which is the CAP 253, which is the Kenya Medical Practitioners and Dentists Council, which has particular functions, like I said earlier, which registers and licenses facilities and persons themselves who are supposed to provide the services. Now, in this law, we have other laws under it, whereby the definition of norms and standards of care, as well as standards of practice, are supposed to be defined by that mother law, that's a CAP 253. But it appears that in my observation and experiences, we have loopholes in those particular regulations that define the norms and standards of care. And because of these challenges, we don't have efficient service delivery, you don't have enough providers in the facilities, And that keeps on now limiting the right of realization of the right to healthcare. So those are aspects that may probably be required to be looked at. We have the functions of the Disciplinary and Ethics Committee. That's another body below the under the Kenya Medical Practitioner and Dentist Council, which has a tribunal-like status. It looks at patients' complaints, facility complaints, payment issues, and when patients are not satisfied, they're supposed to lodge a complaint to this body. And a costing is supposed to be shared, a date of hearing is supposed to be shared, and patients are supposed to be invited with probably their counsel and to defend their case against a provider who's probably breached the right to care. And that function falls under the Medical Practitioner Board Council. We have the implementation of patient rights and charter. Again, that function is defined under the Medical Practitioner Dentist Council. Again, doctors' rights, sometimes you have doctors who've been probably being mishandled by the facilities, or doctors having conflicts between them amongst themselves. And this issue is supposed to be dealt with by professional associations or by the Medical Practitioner Dentist Council. So that is again to still continue to ensure that the right to healthcare is still delivered to both persons, that is the patients. We also have new emerging issues under the Medical Practitioner Dentist Act, the access to information issues, whereby you have issues of breach of data, breach of information. And again, Medical Practitioner Dentist Council is having authority and jurisdiction to deal with that particular kind of breach. So an overall observation of this law, CAP 253, you may want to find that it has taken up too many functions, and a critical assessment may be probably better done whereby some of the functions may be separated from the body and be given to specific entities, either like bodies or departments or directorates under the board, so that you can have more efficiency towards the realization of the right to healthcare. We have another thing that could be probably a good thing in the Kenyan space, the creation of a healthcare ombudsman. This is someone who can probably oversight the right to delivery of healthcare between patients and doctors, as well as facilities, other than having all those functions mixed up under the Medical Practitioner Dentist Council. So those are loopholes and challenges that going forward may want to be looked at. Again, in the digital age space, we have issues with data management. You probably want a patient to be able to know who is their provider. A patient should be able to go on the internet, visit a particular facility, and check who's on duty and get seen at a particular facility. And if a complaint is arising, a patient should also be able to trace back just by clicking on the phone and knowing where they were treated at and who was on duty and report a complaint if that is the case. So these are things that probably will come in later as we evolve in the issues of challenges in the healthcare space. Again, something else that we can compare with other countries, like in the case of South Africa, we've seen that their medical and healthcare bodies are all under one roof. And in Kenya, we've seen doctors, dentists, pharmacists, clinical officers, nurses, pharmaceutical technologists, nutritionists, everyone is in their own house. They're all doing their own things. So that aspect of separation of duties probably has a way whereby we've not been able to realize the right to healthcare. And it's my observation that if probably all these bodies were under one roof, under one direction, and clearly regulated, the right to healthcare will be probably realizable in a more efficient manner. So we look at the Healthcare Act, which now again defines other bodies on how to realize and deliver the right to healthcare. Under this act, you have two bodies, the Kenya Healthcare Professional Oversight Authority and the Kenya Healthcare Human Resource Advisory Council. Now, the roles and functions of these bodies are stipulated there, but what you have observed is that the capacity of these boards and the representation of persons, that is the stakeholders, in each of these bodies is not that well balanced. And that means that the realization of the right to healthcare may not be achievable, because when you have missing stakeholders in some of these big bodies, it's easy to not find the direction where you want to go to, because that person is not represented to speak about the thing that needs to be delivered regarding the right to healthcare. We also had the emergency fund introduced in the Kenya Healthcare Act of 2017, but this is yet to be operationalized. But so far, we've seen that the NHIF is trying to bring an aspect of coverage of the emergency care services, and we are yet to see whether that happens. Again, in this act, we have schedules that define facility staffing levels, norms, and standards, but the particular numbers of staff. Remember that 4x4 vehicle that I showed earlier. One of the wheel is the human resource factor. If the wheel that moves the human resource for healthcare is not functional, then you're probably not going to achieve some of the things that you want to achieve the right to healthcare. So those are some of the things that are discussed under there. Again, in the same act, it is introduced that you have the primary care networks, the primary healthcare communities, the community healthcare workers, and the community healthcare volunteers. So these are persons who are supposed to work at the primary care level to continue to provide the preventative and the healthcare services, so that you can get more persons not being eliminated from seeking healthcare from the community. I have another law which I've talked about, that's the Cancer Prevention and Control Act of 2012. And this again, in a way, you'd want to look at it like it does duplicate roles with what is happening at the Ministry of Health. The Ministry of Health has particular duties, but the duties that are undertaken by the Ministry of Health seem to somehow clash, or somehow it's just a parallel program that's doing almost the same thing. So you have the National Cancer Control Program and the National Cancer Institute of Kenya. So the objective of these two bodies, they require budgets, they all want to go the same direction, but it's, in my opinion, it is like an observation of duplication of functions, whereby funds could probably be efficiently used if all was done in one direction, in a clear manner. Again, aspects are rising up of data protection, what I shared about telemedicine, health, e-health, and teleradiology, and as well as mobile health. We have issues arising where we have doctors either practicing from a different country, like you have, let's say someone is in Tanzania, wants to see Kenyan patients, where they can still provide services to Kenyans, based on the fact that you have the East African Community Registration, Cross Registration Act, which provides for providers in the region to provide services to Kenyans in the locality. But the question arises now whereby you have other providers. Can a doctor in the UK, registered in the UK, see a patient in Kenya? So those are rising issues that will probably require more laws to be defined or regulations to clear out how you have patients getting still protected and not getting exploited by persons who are probably not qualified or registered, but they're based outside the country. Again, we have issues of governments and the county government using different healthcare management information systems. Since devolution started in 2010, you have had different governors coming in, and every time they come in and set up the management information systems, that's like the other wheel of management of services. So each governor will probably come, install their own platform, and after 5 years, another governor comes in, installs another platform. So that loss of data all the time when the governments keep changing, and the fact that those platforms are not communicating and there's no consistency in how, let's say, Baringo and Turkana is handling the patient data, there's a likelihood of our country not realizing the proper right to healthcare and how if healthcare management information is supposed to be done. So we speak about the healthcare, the Pharmacy and Poisons Act, and this is now an act that was meant to provide for the regulation of the pharmacy profession and the trade in drugs and poisons. And this act provides again for functions between pharmacists and pharmaceutical technologists. These are particular persons who are skilled differently, and the country needs to realize that it's two professionals, these two cadres, they're very important in the country. And it's good to assign the two persons or the two cadres enough duties to continue to promote the right to healthcare. Because when you use one particular cadre and you leave another cadre, then that means the right to healthcare may not be effectively realized towards the quality framework that you have seen there a while ago. So that aspect of accessibility, you probably want to access a pharmaceutical technologist and still access a pharmacist, because failure to access one will probably be detrimental in the care and quality that you probably accessed as a patient. So this board again regulates the aspects of importation of drugs, and again it decides on how drugs should be sold in the country. It has a way of how it checks on quality of drugs, how fake medications are checked on, and it also has a way which can probably be better defined if there was a way to have over-the-counter medications control, because recently we've seen the aspect of antimicrobial resistance menace. We're having drugs being sold all over without proper prescriptions, and that affects the right to healthcare. Yes, you want to get that accessible, but if you can go and serve yourself in a way that it's detrimental to your health, it doesn't benefit you. It gets to make more access in this case becomes more expensive, because the more resistance towards antibiotics comes in, you're not able to access more affordable medications. And the more affordable medications are probably more expensive whenever there is drug resistance. So the board still, the Pharmacy and Poisons Board also does drugs, health, products, equipment, and technology regulations. And now this is also an aspect that has shown up in the Healthcare Act of 2017. There appears to be like a clash, and the two sections, section 62 and 66 of the Healthcare Act need probably to be aligned with the PPB regulations. So again, we look at the KEMSA Act. Now, this one again provides for strategic purchases of medications, equipment, drugs, and this is for the supplies towards the public sector, hospitals, as well as the private providers. And challenges facing KEMSA, you've all seen that in the newspapers. You've seen issues of corruption, stockouts, and county governments not paying bills to the KEMSA board. That affects the delivery of the right to healthcare. So it is my position that probably some of these aspects will be streamlined. You have a new now board and a new CEO coming up, and we hope that this aspect that you've seen in the newspapers, in the news all over, will probably be streamlined for this act to deliver what it is set out to do, so that you get to have the right to healthcare. Now we look at the aspects of the human resource. We have the human resource that we have the employment. Strikes all over. Since the last 10 years, you've seen like over 60 strikes have happened from different cadres, different institutions. And all this is around issues of salary delays, training and development, promotions, job satisfaction, mental health issues, safety at work. We have proper laws, like my previous speaker, Dr. Aya, had said, we have robust laws, but the implementation of these laws seems to be a challenge. But the aspect that need to be probably be championed for, and that's why the unions exist, to try and check whether the government and the employers are doing the right thing towards having the employees realize the rights to a fair work relationship. Again, new aspects that are coming up with aspects of climate change, and we have aspects of the healthcare workers being overworked because of probably changing disease patterns. And this is something that the governments need to plan for, because when the disease patterns change and you have increased disease burdens, you probably want to employ more workers, and workers who are probably given safe workspaces so they're able to provide more efficient services without having themselves get affected by the occupation, the space that they're working at. So that is something that needs to be looked at. You had issues of clashes between the PSC and SRC towards the terms of remuneration between the entitlement of the workers. And this has been a thorn in the flesh of so many persons, and we'd wish, if it was possible, to have a way that these laws, they don't have this, the conflict between the two laws, the SRC Act and the APC Act, gets minimized so that you can have better cooperation and better interdependence between the two laws, so that workers in the healthcare space get to feel comfortable and to provide services in a happy manner, in a way that patients are enjoying whatever is happening there. We have the insurance law, and here we have the IRA. The IRA is supposed to regulate how insurance packages are supposed to be costed, the underwriting of premium products, and as well as how those particular products are supposed to be sold to persons. This as regards the aspect of purchase of private insurance. And something that probably has not happened is the aspect of NHIF control. So the NHIF seems to run away from the insurance laws. It operates in a way that doesn't want to look like a proper insurance. And that is why you've now seen recently the aspects of the insurance, the NHIF fund, having less funds to pay for services. And that again affects the right to realization, the right to healthcare. And it will probably be better if NHIF was brought under the insurance laws so that they get to conform and have enough capital ratios to sustain their debt burdens as regards what they have chosen to underwrite. That's the provision of universal healthcare for all persons. Again, I've seen issues of provider panels, cartels, and the Association of Kenyan Insurance. And here, provider panel, we talk about the aspect that we don't have all doctors, all providers providing services in Kenya. Assuming a situation where we had all doctors being free to see anyone, any patient, without a panel being put as a front or a block for a person to access care. Because those blocks appear like a way to minimize free access of patient care. A patient probably go to a particular provider and they're told, I cannot see you because I'm not empaneled. Or if I see you, I will not be paid, so I will not see you. That limits the right to care, because those panels, again, they act like cartels. Those persons who have been empaneled, they want to restrict other persons from providing care. And because you have few players, you have the cost of care going very high, because they're the same ones who want to just enjoy that insurance money. So if it was possible to have a panel disbanded and have all providers go ahead and provide care to all persons, then you have more competition, you have more access to all patients, and everyone is happy. But they have their own organization, that's AKI. It also seeks to counter what the providers and what the hospitals want, and probably what the state would want. So the things and interests that will need probably to be balanced in the healthcare space. Again, you have seen the aspects of care packages and cost of care, and you have different providers charging differently. There are packages that are being designed. And now these packages, again, remember earlier, like I talked about the Medical Practitioner Dentist Act, it provides for costing of the care or professional services that are supposed to be offered. But you have now someone else who has no authority setting the price of a particular product. Now that aspect of clashing between prices set by NHIF, prices set by private insurances, and prices set by the medical regulator, all these prices have an effect on how patients want to realize the right to healthcare. So if it was done in a conforming manner whereby everything is well defined, everyone knows this is the person who sets the prices are fair and equitable, then you'll have better realization and access to the right to healthcare. Again, it will be a better position to probably differentiate the difference between hospital costs and provider costs, because the cost of care is always said to be very expensive, but it is not expensive. The cost of hospital care is always expensive because you probably have someone visiting a hospital and getting admitted there and paying like 30,000 per night. But the doctor who is seeing them, they're probably not charging that much for the service that you have already offered. But the cost of care will be said to be expensive. But it's not because the doctor is expensive. It's because of the other extra costs, like the hotel-like care that patient you probably want. Everyone wants to have like an aircon in the room, TV in the room, sofas, visitors, and all that. But those things cost money. And they're not real actual cost towards healthcare. So healthcare is affordable. And if these two factors of paying for providers and paying for hospitals separately were done separately, then you realize that access to care is more efficient even in the public hospitals, because they know that hotel-like environment. Something else that we talked about is the issues of fraud. You have doctors being accused all the time of causing fraud, but this is a systemic issue whereby you have many players, and because of this, you probably will not want to just blame the doctor for fraud. And if there was a way to probably investigate all cases, it is possible to have all those persons who've been playing those games to be prosecuted so that can have more affordable care, because the cost of fraud, it results to increased premiums and limited access to care. So something else that could probably be designed here is an issue of anti-fraud levy, which can be levied and built on upon hospitals or providers, so they get to have enough funds to check and see which persons are actually doing this as things of fraud. Because I don't believe it's not all doctors who are involved in fraud. It's just a few persons combining, including with the persons in insurance companies as well as the NHIF, who are leading to this loss of funds, resulting to a sustainable delivery of care. Again, you have multiple care delivery and billing systems, and all this is an aspect of competition in the market. You have NHIF with their own biometric systems. You have a company known as Smart with their own biometric system. You have Slade, another company with their own biometric system. CIC, Jubilee, they're all using fingerprints, others are using faces, pictures, X-rays, radiographs, and all this differentiated mode of delivery of service or access to service is limited in a way because there is no conformity in a particular modality. So it would probably be better if there was a regulation to harmonize all these companies' operations so that patients know whether they're fingerprints that are going to be used, whether it's faces that are going to be used, or pictures or other things. And again, how this information is supposed to be shared between different providers or different hospitals. That is something that's very, very particular. And if it's not very clear, it limits the access to care. We have the Competition Act. And again, here the functions of the Competition Authority of Kenya is defined. And this is a body that is set out to check on competition in the healthcare space. But not much has been talked about the aspect of regulating competition in Kenya. So we have very few providers regulating or controlling or acting as monopolies towards driving cost of care. And these are persons who probably are now the empaneled persons. If the competition law is set to work, then you cannot have panels providing care while others are not providing care, because you want everyone to provide care freely without restrictions. So something that need to be dealt with. Again, the Competition Act sets the standards in space, and again, controls how mergers and acquisitions are supposed to be done. You have seen, like in countries like the US, big hospitals, when they merge, they want to control price and cost of care, because now the big players, they want to define how much probably a particular service will go for. So the Competition Authority comes in to check whether you should all remain as individual providers without merging in and coming to bring monopoly towards offsetting the way prices are probably being in the healthcare space. Again, the body, Competition Authority, serves to provide consumer protection as well as abuse of power, controls against abuse of power, buyer power, whereby goods and services are delivered in a way that it's not clear. And one of the parties in that arrangement is infringed. The rights of the business is infringed. So you can have like the hospital providers or the hospitals themselves. They're either delayed to be paid promptly, and because of that, they'll hike and put a markup on the delays of the payment that's supposed to be due. That again affects the cost of care, because when you have constant delays, you probably want to charge an interest or probably charge more premiums for whatever is coming up. So the Competition Authority serves to control against delays in payments, and that is because all players in the service delivery sector should be in a fair ground whereby nothing is placed to probably make the other person change the price to a particular advantage. Again, on the issues of paneling, I talked about restrictive trade practices, the thing that we probably want to be checked on the issue of anti-competition laws. Now we look at the NHIF Act. It's a new one, amendment last 2021, and it's still undergoing public participation. Again, it provides for paneling, which is something that is probably will have to be looked at. Again, there's need to probably provide for, well, check whether the NHIF has capacity to set prices and differentiate between prices of public care, private care, as well as hospital and provider care. If all those units are costed differently, then you get to know the real cost of care, and that affects how care is to be delivered. You have aspects of pre-authorization, facility selection, system downtimes, and denial of service. NHIF has faced all these issues. You have patients suffering with pre-authorizations, treatment is requested for today, it's approved a week later. And again, that means the immediacy or the promptness of what you wanted is not realizable. So you get frustrated with the system, and next time you end up not even paying the premiums. So those aspects of inefficiency by the board, NHIF board, need to be checked on so that you can get our patients being happy with whatever they're seeking. Again, you have issues of benefits packages and exclusions. You have NHIF having differentiated packages, which are not, everyone will probably want the best, but again, not everyone can afford all those packages. So the government, as well as the board, they have a duty to come up with a package that everyone can get at least a basic or essential care package. So wherever they go, they get emergency care, ambulance care at any level of facility, whether it's a public or private facility, because that is what is supposed to be defined by the payer. Again, there's the aspect of now the social tripartism, which is like an aspect of different players paying for care. In the proposed regulations, you have the employee paying for their own care. That is as per the 2.7% that has been suggested. It is a better position to have the government and the employers themselves to pay towards this care, because all these persons in this healthcare space, they're all benefiting towards something. The government wants its people healthy. The employer wants people, the workers who are healthy. So it cannot be the duty of the employees to pay for their own care themselves alone when they keep to work for the government and they keep to work for the employer, who is not concerned with whatever is going in the healthcare space. So all these players have all to come together and contribute towards that cost of care. Again, it's a good thing for the NHIF to provide for the UHC delivery, and we wish to have that delivered in the nearest time possible. So other things that have come up with the aspects of public finance management, you have issues of clashes between the facility improvement funds and the aspects of new bills coming up. You have the national and county facility improvement funds, and these are things that are supposed to improve public facility financing, and it's something that's very, very important because you want public facilities to be able to compete with the private sector. We also have the aspects of management equipment scheme, where you have seen county governments crying for that the national government played them on the aspects of financing of medical equipment. Those are aspects that contribute to the cost of care, because if public sector is not working, patients will visit private hospitals where those equipment are present. So it would be much better if this equipment scheme was probably maintained and in a more transparent and accountable manner. You also have the issues of public goods bill, which is not a true experience as such, because you have most facilities in the country. You have too many facilities. Actually, we've surpassed the ratios of facilities per population in the country. But the aspect of these facilities is that they're not staffed. They're not staffed. You have enough workers, but they need to be staffed because the norms and standards of staffing need to be established and upheld. Something that will probably be contributing to the aspects of the increased wage bill. You have aspects of duplication of roles and ghost workers employed in public space. So something that need to be checked about. Now the County Government Act introduced in 2012, and it also defines different functions of different bodies and different entities. And if everything was run smoothly, you probably have better functions delivered as per the Schedule 4. And where you have other aspects still under Schedule 4 that are common health determinants. And if these are not checked at the county level, then that means the right realization to healthcare may not be realizable. The aspects of water being absent in most counties, sanitation issues of the counties, food, nutrition, and the recent issues of housing. If you don't have proper adequate housing, that means then you'll probably be living in squalor, and you probably be exposed to more hardship that predispose you to disease conditions that now make you to spend more on care. Aspects of the Intergovernmental Relations Act should come in and try and smoothen how the national and the county governments deliver the right to healthcare as it was devolved. Again, you have seen issues between management of health, human resource for health. You have clashes between the PSC Act, the Health Services Commission as a proposal, as well as the Employment Act. So this is a thing that need to be looked at how the CPSBs, PSC, and Health Service Commission, as well as the Employment Act, get to be formalized in a way that it delivers more efficient care as regards the human resource for healthcare. And then now I come to the new law, the 2021 Act, the Public-Private Partnership Act. The government is probably having a strain in some of the things, so that things that can probably be privatized by combining partnership between the private and private sector, public and private sector, to deliver more services, like the aspect of mass equipment. So you can have someone probably coming in, set up, and have a way that they're paid over time, and get the budget of the government to become more leaner and more manageable whenever someone comes in to intervene. On the aspects of education, you have the University and TVET Act, the role of QUER, KMTCs and KMTCs Act. There's need to standardize courses, provide for course progression, and minimize conflict between the cadres, because it needs to be, persons need to train in a way that they know where they're going and they know which scope of practice or which service they're supposed to train in. It meets the sense of having persons qualify with different qualifications and end up not providing services they were supposed to, or competing with other persons who are better trained, but themselves are not trained. That, yes, you now get to affect the cost of care by providing too cheap care in a way that it's not the best quality. And because it's not the best quality, that means you spend first time and then you spend again to seek for the right person to see you. So that's something that needs to be checked on how the courses are programmed and how persons get to progress and how care is supposed to be accessed. Again, university education has gone up, and you've seen the new funding matrix. So the thing that we want to talk about, the aspects of diploma, degree programs, postgraduate programs not being funded by the government, as well as the aspects of research not being funded by the government. The government will take charge of these programs, because without postgraduate studies, you cannot have specialists in most of these fields. And without specialists, that means staffing ratios are minimized. That means care will always be sought outside the country, because you don't have enough specialists in the country. It's something that the country needs to plan to continuously have these persons providing for care. So we look at what has been discussed elsewhere. You have the issues of WHO building blocks and 6 building blocks. Like I earlier said, you have the service delivery, healthcare workforce, health information systems, access to essential medicines, financing issues, leadership, and governance. And again, we're doing this for the people. Now that's like the 7th building block. We've had different frameworks of care quality delivered. You have issues of availability, accessibility, acceptability, quality. All these frameworks, they have an interplay, because it all wants to ride to one place, the right to realization, the right to fair, to equitable, high standard healthcare. So that's a pictorial that shows the WHO system towards what they want to drive to. We want to go to equitable healthcare of the highest standard for every person. So in conclusion, should we have more laws? Should we have new strategies? Should we have new opportunities? What does the country want? We probably want to say, let's create more laws, or minimize the number of laws that you have, so that you have more efficiency in the number of laws that you have, because we really have a lot of laws on healthcare. But it seems like we're just stuck there talking about laws every day and nothing happening on the ground. So new strategies probably could be sought, whereby we're thinking of either consolidating, either funding strategies where you have PPPs, and probably outsource other functions the government is probably not able to. You can have norms and standards defined better and implemented, the aspect of service delivery, staffing ratios, space dimensions, equipment, and technology. All these things that need to be looked at in the try to deliver the best healthcare in the country. Opportunity in the healthcare space, we want to look at business in healthcare. Is it a purpose to make profit? Why are persons going to private health? What are the values of these businesses? Do they want to probably balance what the government is doing in promoting the right to healthcare? So these are aspects that need to be checked, because you've seen that the private sector is wanting to just go for profits and not realize the right to healthcare. We want to look at Kenya. Can Kenya export the healthcare? If the healthcare, human healthcare for the human resources for health, well, if the discussion is that we have enough and excess numbers of persons, but that's not the reality. The reality is that we have a shortage of Kenyans in the country. We probably have a shortage of about over 25,000 healthcare services providers, and because of this, the right to healthcare is still limited, because the training issues are not checked. Employment issues are not checked, facilities are not staffed. Those are things that need to be looked at. Again, we want to go by Vision 2030. We want Kenya to be a medical tourism destination in Africa. This is something that the country can do, but it has to be focused for us to realize the right to healthcare for all Kenyans, and for ourselves to be where we want to be. So I conclude there, and I finish with that picture, and I'd ask questions whether we want to just have attractive things as regards policies, documents, laws, but nothing on the ground. So we want our laws to work. We don't just want attractive things all over the place. So that's my call for you today. Thank you.
Thank you so much, Dr. Kahura, for that insightful presentation. I like your conclusion. Do we need more laws, or we need more strategies and laws that actually work? So now at this juncture, we are going to move to the plenary session where we'll have the questions and comments from our participants. Because our time is spent, we'll address a few of the questions. So now one of the questions, and this is directed to Dr. Oyaya. What is the human rights response, and how the Kenyan legal framework marry each other in relation to surrogacy in attaining sustainable right to health in Kenya through assisted reproductive means from a healthcare aspect? Dr. Charles, you can unmute and address that question. I hope you've gotten it.
Yes, I have. Thank you, and thank you, Sharon. I think it's asked by Sharon.
Yes.
Sharon Mwendo. Probably I may not be in a position to answer it very directly, but just to mention a few things. Number one, that indeed the right to reproductive health and reproductive health care is guaranteed under Article 43, 1A. And I think that is clear and is part of the highest attainable standard that we have spoken to. On the issue of surrogacy, you know, is a very contentious issue, and probably Dr. Kahura can speak more to this, particularly from a regulatory point of view, ethically and otherwise, but it is not new, because even within our own context, the whole question of surrogacy was there. And when you look at the statement around the right to reproductive health, it does not indicate whether it's only the right to reproductive health in a natural context or assisted. But when it comes to the exercise of this, then it brings in a number of, if you like, ethical questions, and particularly looking at the commercial side to it. And particularly when we look at it in the global context. You can also read this in relation to the whole question of recognition by the Constitution on the right to life, and not only right to life, the recognition of the family as the foundation. So these are questions. It's not a question of right or wrong, but the law is, the Constitution is clear as a right. Now, the extent of its operationalization and taking into account the various questions around the commercial or commodification of it, and also the ethical question that relates to it, that comes in, and I think that falls squarely on the purview of regulation. I think that is what I can say, but in the broader context, it is provided for in the context of the statement on the right to health. Thank you.
Thank you, Charles. Dr. Kahura, might you have any perspectives on that issue?
Thank you. Well, the issues of right to surrogacy, it's still a work in progress. We have a general law, and some persons have actually pursued that claim in court, and the courts have pronounced themselves on the issue. That it's a contractual arrangement that has aspects of moral and ethical issues that probably we are yet to get to accept it as an African nation. But you see countries like Estonia in the European nations, they have already set such laws and they're working and everyone is happy. So in the proposal, as per the new government coming in, the fifth administration, I've seen the reproductive law, the bill. There's a bill that has all those clauses. that is still supposed to undergo a first reading. And when that time comes, I think those things will be better placed, and most Kenyans will realize the right to reproductive health as regards the persons who cannot get their families set up. So it's something that's still coming, work in progress.
Thank you, Dr. Kahura. Vincent?
Okay, thank you very much, Christine. I'm just looking at one of the comments by one of our participants. His name is Joab Ogalo, and he's more of agreeing with Dr. Kahura on the issue of unsafe healthcare practices. And his comment is unsafe healthcare practices is costly, financially and emotionally draining. Cost of retreatment, loss of valuable economic time, cost of litigations. Let us advance access to quality, safe, affordable, and patient-centered healthcare, which really resonates with what Dr. just said, the cost of unsafe healthcare practices. So yeah, and just to read another comment from Joab Ogalo, this is still the same Joab Ogalo. He says that this is an exciting session. In relation to Dr. Oyaya's presentation, I noted the need to incorporate the element of patient safety as an ingredient measure of right to healthcare. As you may note, the surge in unsafe care, negligence resulting in patients dying or suffering injuries is an hindrance to achievement of UHC. The need for patient safety and satisfaction must therefore be never ignored in the advancement of health rights. So just to thank Joab Ogalo, he says that he's the chairperson of Confraternity of Patients Kenya. He's really raising very critical comments and even beefing up the conversation as our panelists have been speaking on. And maybe just to quickly ask Dr. Charles to comment on something that he raised during his presentation, maybe to clarify in like a minute or two. You spoke about inadequate physical decentralization within counties, limiting the ability of departments and health facilities to offer quality healthcare services. Maybe you could quickly expound on that point for like a minute. Charles?
Thank you very much for that. And thank you, Job, as well. Just to mention that the issue of patient safety is captured within the framework on quality of care and standards and protection of the rights to safe care, I think, as has been mentioned. On the question of inadequate fiscal decentralization, I want to mention it in two dimensions. Number one, the whole question of devolution of healthcare is provided for, and it is vertical between national and county government, but it is also horizontal in the context of both national and county government, that yes, it is one of the principles and values of governance that devolution and exercise of that power is one of the guiding things. So if you combine that with the principle of subsidiarity, whoever is best placed to provide a service, for example, should do it, whether in the public or private domain, and that brings in the whole question of delegation of a given function to a given entity, if they are best placed. We understand it from that point. The second point is that our constitution does provide two principles of decentralization: the devolution, which I've talked about, but further requires a decentralization of services from the center to where it is needed, insofar as it is efficient and will make the service be as proximate as possible. That you will find under Article 174 as one of the objects of devolved government. But if you also go to Article number 6, is a requirement on the part of national government to do that. And when we talk of functions, there is the function side, then there's the fiscal side. Now, the fiscal power is devolved, again, vertically between national and county government. But there is a further requirement. For example, I think under Article 176, that one of the principles of devolved government or county government is further decentralization. And that is what is spoken, if you like, under Section 48 of the County Government Act. What that basically means, that if you take the fiscal power within the county, it has to move from the center, let's say the county treasury, from the county revenue fund. And that is why the law, both the Constitution and Public Finance Management Act, does provide that apart from the county revenue fund, you can create other funds. That is an element of further decentralization and delegation. Then two, from the county treasury to various departments. Let's say the Department of Health. That is why we have a chief accounting officer. That is why we have an executive. Now, the question is, what powers have been legally transferred to them or devolved to them or decentralized to them? We are talking about FIF. That is Facility Improvement Fund, to enable, let's say, health facilities that are charging for services to retain a certain proportion so that the operations can continue. That is an element of decentralization. You go to many counties, and in short, you will find that element. Even when money goes to county revenue fund, it does not find its way to where it is actually needed. And that is one factor of not only underfunding, but even disbursement to enable services be provided. If it comes in, let's say, conditional grants, let's say from national government or unconditional, it goes to county revenue. How does it move from there to where it is required? So that is an aspect that if we are to deal squarely with financing within counties, we have to deal with. None of the counties have enacted their own public finance management law that is appropriate to their context. That is not a limited legislative action, but they behave as if it is limited because it is serving those you can imagine, as I also imagine. Thank you very much.
Thank you, Charles, for your response. So I'll read one more comment and question from Jessica Damaragak. She says, good evening. I'm happy to join this discussion all the way from Eldoret, Kenya. My question is with regards to the Finance Bill 2023 proposed amendments that touch on health. Will they truly aid in access to healthcare, and are they the best approaches towards the achievement of the highest attainable standard of health? And she's also asking for the presentations. So both Dr. Charles and Dr. Kahura can respond. We start with Dr. Kahura. Do you think?
Well, the finance bill has good parts and bad parts. And regarding healthcare, you've seen vaccines and vaccination programs being exempted and be reclassified in a way that they should now be more accessible. But we've also seen that another tax has been introduced that is regards now the manufacturing of persons setting up entities to create vaccines in the country. And that may probably also not be the best thing that we want, because 2 years ago, we had vaccines set up, the manufacturing being set up in Kenya for vaccines. But then again, it seems like we're going to stop that or stop the progression of that, and that may not probably lead to accessible care. There's also something that has been given, like an exemption again of facilities. These private facilities. You have hospitals of up to 100 beds. Whenever they want to import or bring in equipment, they probably will get some tax exemption, some tax cutting. That's because they should set up more private care. But the question is, will these more private facilities that are being set up provide affordable care, or should it be just a repeat of the same thing? You open up the space, bring up more persons, and they all want to for profits. So if the public sector was probably better functioning, we probably even not even have all this race towards opening up so many facilities. Because as we speak right now, as per the WHO standards, we have enough facilities in Kenya. Something else that's also been put up is the aspect of drug manufacturing and pharmaceutics. That again, there's a tax introduced, and that could probably result to a rise in cost of medications. But things that need to be checked in, because we want affordable medicine. We don't want costs just rising up patients are already taxed in other aspects, and there's reduction of the income in the households, and that may limit access to care. Again, you're not even be able to afford paying for NHIF, which is supposed to be about 1,000 bob. So if other taxes are so high, then you don't even have enough to pay that little that you should pay towards NHIF to realize that care, right to care. So those aspects that need to be balanced in the coming weeks. Thank you.
Dr. Charles, any comments on that?
Thank you. Just in addition to what Dr. has just mentioned, the finance bill is a national government instrument. The law, the constitution under the chapter number 12, as part of fiscal powers that are vested in both national and county governments, is to generate revenue. And that can be generated through taxes, through levies, and so on and so forth. And in this case, the national government has the power to plan and just like the counties, to plan and budget. And on the basis of budgeting, then they appropriate. And on the basis of appropriation, then they disburse for purposes of service delivery or for purposes of operation. What the finance bill is actually saying is that the government, national government has planned, has set priorities, is coming up with budget estimates. That budget estimates will have to be financed. How is it financed? It's financed principally through taxes and also through debt financing, so to speak. And they have set their target on how much they would like to raise. Now, the question that I think is coming in, and is through the finance bill, that when it becomes an act, gives them the power to collect that revenue, is the equity and fairness question. The finance chapter is clear on fairness, on equity, on accountability of any resource, and also very clear on double taxation. And not only for now, but also for future generation. And that is where, for example, debt is coming in. So if you look at it in the context where we are, in the context of high costs of living, people are questioning not the entire finance bill, but certain aspects of that finance bill that seems to be, if you like, blind to the reality of life. So I think it's a question of equity, it's a question of fairness. And if somebody was to go to court, of course, now Okia has gone to court to challenge it, but I think it is a little premature. Certain aspects of it can be challenged once it is passed. And therefore you say this one is unconstitutional and therefore should not see the light of day. Counties are also levying revenue and they have their own bills, you know, in relation to this, that will give them the power to collect the revenue that they need. At that level, people may also raise questions, like, for example, how much are you charging for business permit? You know, would it be fair? Will it be contributing to productivity and so on and so forth? So that is what probably I would say at the moment, that one looks at it in context, not in terms of the power of the national government to generate revenue through taxation, and which is given through the power of finance bill. Thank you.
Thank you, Charles. Just one question on health financing. The Budget and Appropriations Committee has just published its report on the national budget estimates that are going to be read this week. And some of the recommendations they are making to the different national executive ministries. For example, there's a recommendation that the State Department of Medical Services should provide for a clear implementation framework for the hiring of 44,000 community health workers as provided for in the 2023-2024 budget. They also make recommendations for relooking at the NHIF framework and also setting up the emergency treatment fund. So now, from the report, we identified that the health sector is underfunded. Do you think some of these recommendations are realistic, considering the issue of underfunding and even the constrained fiscal space that the country is currently experiencing? That question goes to both Dr. Charles and Dr. Kaura. Dr. Kaura, you can start.
Okay, thank you. Well, the aspect of contribution towards NHIF, you have seen last week, the government had not paid its money. It's part of the Linda Mama, as well as other funds that the government is supposed to contribute towards NHIF. Again, NHIF, it seems like it has run out of cash, and it appears like it's not able to meet the service, to pay for the services that have been rendered. And last month, you have seen facilities writing notices that they're stopping to see patients. So that arrangement should still be maintained, whereby NHIF should pay for services as they enter into contracts with facilities, and patients, as they're required by law, they should continue to pay, because you don't pay again, you default on your coverage. That means you go to seek care and you'll not be able to access the benefit that you wanted. So it's my plea, no matter whatever is happening in NHIF, funds loss, and probably funds not being available and accessibility issues, you continue to pay, because that's your duty as a citizen, to pay to get a guarantee towards that minimum care package. As regards the KNPDC acting as a tribunal on issues of medical, legal claims and complaints, well, you cannot lodge the complaint in two places. The first place you probably have it had at the disciplinary ethics committee before it gets had before it's now finalized there, and after that you're given an order or a decision that you cannot go and implement in the courts of law if the parties have failed to implement whatever was ordered by the tribunal. But there are aspects of healthcare complaints that are probably away from the jurisdiction of the Kenya Medical Professional and Dentist Council. Those ones can go straight to the court. So like aspects of now billing, and that's more advanced rather than what the board gets to do. So aspects of medical malpractice, they are more clear, they're more defined than aspects of service delivery. So aspects of financing, effects of equipment, so those ones will probably go elsewhere. Contracts not being paid in good time, or interpersonal issues, most of those will probably not be had at the regulator council. Again, you have the aspects of our bodies being, or providers being in different bodies. The nurses, doctors, dentists, dentists and doctors are in one body, pharmacists are elsewhere, nurses are elsewhere, clinical officers elsewhere. Well, it's how the law was made in Kenya, and probably by that time, it was better to just create a law for every cadre that's coming up. Get nutritionists, create a law. Get lab people, create a law for them. So you end up now having a lot of duplication, a lot of probably inefficiency in all that. In my position, it would be much better if all these boards were probably placed under one roof. It will probably require legal redesign of the sector and have different boards now. You have a big council, and under the council, you have different boards as per the different cadres. And with that, you have more efficiency and have one common language in how healthcare should be delivered as a function. So that's what I would say. Thank you.
Dr. Charles, any comments?
Thank you. First of all, this is actually the demonstration or the challenge of the lack of clear guidance on how you exercise what may appear as concurrent functions. On the question of community health promoters, that is, I think now what they want to call it. First, I would want to mention that there is a bill before the Senate on the community health service. It's been there for the last 3 or so years. But on the question of community health volunteers, if probably I just showed, the health service structure, it is actually part of the county health system. And the national government has no business financing it. But it can as coming through the conditional grants. But why should the government, the national government, not have that money go to the counties to fully strengthen the community and county health system? This is where, when we talk about national government political will to make the pollution system work, comes into play. So the question will come, on what basis will it actually finance this? And it has continued doing that. Maternal, reproductive health, newborn, whatever, HIV, they are actually within the county health system, but they are still being managed at the national level? So I think those are questions that we need to clearly address, but I think they, as they say, they will cross the bridge when it is there, when they get there, but certainly it is offensive to the divorce system. It's not respectful. The Constitution says that each level should exercise their power in a way that respects the other level of government. I think the NHIF question, it just requires, what do you normally call it? What surgery? That thing just needs to be completely relooked at and reformed. The reason why they are in a situation they are, one of it is basically accountability questions, as Dr. had mentioned. But the other question is that as long as the public health service delivery system is dysfunctional, it will not be able to work. As we had said, in terms of structure of its disbursements, 70% of what it collects goes to 30% of beneficiaries in the private sector. So I think those are questions systemic that need to be looked at. From the right to health perspective, there are those who are vulnerable, the indigents. It is curious that under the amended National Health Insurance Fund, that they are making that responsibility of identifying and bringing into cover that responsibility to national government as far as indigents are concerned. So where do you leave the counties to deal with that? So counties are trying to finance their own population to access services, yet you are telling them they cannot do it. They can only do it through national government. Those are questions that we have to address if that structure is going to work. But as currently constructed, it can be as dysfunctional as we are seeing it to be. And what I'm foreseeing in the short run, that even people who are not employed, who are not forced to pay, are going to drop out. And it is going to face even more crisis, because if that card is not of use, then why pay it in the first place? There are also provisions for discrimination. Yes, you will pay, but you will get a different level of service as compared, for example, to civil servants, who will get better care from within the same cover that is supposed to equalize, if you like, access to care. Thank you very much.
Thank you, Charles. So now we've run out of time. So I'll just give our panelists 2 minutes each to just give their concluding remarks. We can start with Dr. Kahura, 2 minutes.
Thank you. So, well, my position is that for us to realize the right to healthcare, we have to be intentional with what we want to do as a country, because we have very good laws, very colorful guidelines, policies. It seems like nothing is happening from my perspective, other than the publication of the reports, which are really, really good if that was actually the actual state of the issue. So as per Article 10 on the issues, on the aspect of the values of governance and what is expected, I believe we all want a good country, we're all patriotic, and we all are transparent and accountable. And if we are to implement the laws as they were and as they were discussed in the policies, then we should have the right to healthcare realized by most Kenyans. And that's what we want. So every day we are pushing and keep to push for that. Thank you.
Thank you, Dr. Kahura. Dr. Charles, 2 minutes to give your concluding remarks. Dr. Charles, are you with us? It seems we have lost him. Oh, he's back. Dr. Charles, we are giving you 2 minutes to give your concluding remarks.
Thank you. Just want to thank everyone who has had time to join in this webinar. Dr. did mention the pillars of the health system. If we do not address the 6th pillar on leadership and governance, then the laws, even if we enact them, will not bring the results that we all desire as far as the realization or the enjoyment of the right to health is concerned. It determines decisions of resources. It determines the delivery of quality services. It determines even the prioritization of the right to health. That is what I would say finally. And just best wishes as you take this forward. Thank you very much and good evening.
Thank you, Dr. Charles. So now I want to invite our Executive Director at ICJ Kenya, Ms. Elsie Saina, to give the vote of thanks, the closing remarks on the vote of thanks. Elsie, over to you.
Good evening, and thank you very much, Christine, and all the participants. I hope you can hear me clearly. I want to just say thank you very much. Let me start by acknowledging all the participants that have continued to be with us since 2015 until now. Just to say thank you for making time and joining us. You've got to agree with me that this has been a very enriching, deeply enriching conversation, which has left us with more questions than answers and a great challenge for us here at ICJ Kenya. I must thank our able panelists, Dr. Charles Oyaya and Dr. Kahuria Mundia, for making time to join us and share your experiences and your knowledge on the subject matter with our distinguished participants this evening. More importantly, sharing the findings of our report here at ICJ Kenya. It's only the beginning, and we are looking forward to even more responding to more policy and legal questions that have emerged, including the nuances that have come from this discussion around, what is the role of artificial intelligence that has really opened our minds here at ICJ Kenya. I also must really thank my colleagues here at ICJ Kenya who've put this together. They have been working tirelessly behind the scenes to ensure that the participants and the panelists are able to get together and deliberate and put together this wonderful webinar. I hope the deliberations and recommendations will, as Dr. Oyaya says, that will move forward and help build our country to better realize our right to health as envisaged and enshrined in our constitution. So I really want to thank my colleagues for moderating, Vincent Kimathi and Christine Akinyi. Thank you very much for taking your time to moderate the session. It's been wonderful to have you there. And our technical team behind the scenes, led by our communications consultant, Joseph, we really thank you for taking your time. Israel and Achaga and team, thank you so much. I sincerely also just express my thanks to the ICJ Kenya Council and the chairman for joining us earlier today and continuing to support our work on right to health advocacy. So once again, ladies and gentlemen, allow me to bring this to a close. And I just say thank you for making time. And we look forward to many more webinars where we'll discuss more important issues around human rights in Kenya and where our country is going. So I wish you all a great evening ahead. God bless you. God bless Kenya. Thank you very much. Back to you at the studio.